Okay, thank you. My name is Qinxia Wang, and this will be a joint presentation with Dr. Shanghong from Department of Biostats at Columbia University. Today we will present our survival-convolution model for predicting the COVID-19 cases and assessing effects of mitigation strategies. This is a joint work with Dr. Wang from Columbia University and also Dr. Donglin Zeng from UNC. Our work has been published in Frontiers in Public Health, and we also have the GitHub page with open source code, as well as the current daily, weekly updates prediction results. So let's first see an overview of the recent prediction result for US using our model. The first two figures are the prediction for daily new cases using different amounts of training data colored in blue. The third figure is our model fit for daily new deaths. And the last one is the prediction for the cumulative death, in which we see that the total number of deaths in the US will surpass 200,000 by the end of September. We have submitted these results to the COVID forecast hub. Here is a result from the forecast hub where different teams submitted their predictions for the 4-week ahead cumulative death. Also, an ensemble model is created from all the submissions, and this ensemble model turns out to have the very good prediction results. Here is a list of some of the model submissions, and we see that our prediction for the cumulative death is very close to the ensemble model. CDC also reported these results and concluding that the ensemble model predicts around between 187,000 to 205,000 total COVID-19 deaths will be reported by September 12. So among all the infectious disease models, there are two main groups. The first group is about the generative or epidemiological models. For example, the commonly used SEIR model. These types of model usually have mechanistic assumptions, so their parameters have meaningful interpretations. However, they often use numeric solutions from ODE, and this deterministic process is often very sensitive to initial conditions. They focus less on the observed data. The other group is about discriminative or statistical models, including regression, time series models, etc. These models are used to describe the observed data, but in many cases, they ignore the underlying infectious disease mechanisms. So our model is trying to find a balance between these two, where we can make use of the disease mechanisms to fit the observed data and also provide estimates of the effective reproduction number, RT. Therefore, we want to build a simple but robust model for prediction and use estimates of the effective reproduction number, RT, to evaluate the mitigation strategies and compare between countries to inform decision making. Here's a method. We decide to use daily confirmed cases and daily reported death to understand the disease spread. And here we focus on the national level data. Our method can account for long incubation period when transmission is happening, but cases are undetected. Also, we can estimate the time varying transmission rate and reproduction number to see the effect of certain interventions. This is the modeling scheme. So on a certain day, some number of subjects initially will get infected, and this number, the number of these new infections is denoted as N. Since then, a part of these patients start to show symptoms and get picked out as cases. The discrete survival function S measures the time of this process, and we denote the number of observed cases as Y. And then there are remaining patients without symptoms who are still in the transmission circle and are still able to spread the disease with infection rate AT. and we denote the number of these latent pre-symptomatic patients as M. Then this equation will give us a convolution update for the new cases using the past infections. To model the time variant transmission rate, we let AT be a non-negative piecewise linear function with knots placed at meaningful events. For example, we can place a knot on the day of national lockdown so that we can see how AT changes before and after the lockdown. The reproduction number, RT, is another very important measure in infectious disease. It is the expected average number of secondary cases infected by a primary cases, accounting for the incubation period. And the literature gave us a way to calculate RT from the infection rate AT. And this RT can capture the temporal changes in the disease spread. So when RT is less than 1, we will expect the daily cases to increase. But when it's greater than 1, then we expect to see more daily new cases. With this estimates in hand, we can then evaluate the intervention effects by looking at how AT changes before and after an intervention takes place. Here is a little more detail about the model training. So when fitting the observed daily numbers, we use the square error loss after square root transformation for observed and predicted outcomes. And also for inference, we also permute the standardized residuals over time to produce the confidence band for the prediction. So I'll let Shanghong present the more about the analysis details.
Yeah, okay. So for the data we use is the numbers of daily confirmed new cases and deaths from multiple public sources, the JHU Center for System Science and Engineering, WHO, New York Times, and also Worldometers, which is a publicly available database for COVID-19 statistics. We conducted analysis for China, South Korea, Italy, and the US. For China and South Korea, our goal are to predict future daily new cases, expected number of cases and latent cases, when RT will be reduced to below 1, and when the epidemic will be controlled. For Italy, we estimated the effects of mitigation. For US, we are interested in evaluating the impact of an intervention at a future date, for example, the lifting mitigation measures that will change the epidemic. To set up the model, we model the infection rate AT as a single piece for China and South Korea and use about 2 weeks data for training. So in this model, we have 3 parameters, T0, A0, and A1, and our goal is to examine the prediction performance. For Italy, we used 4 pieces. We put 1 knot and nationwide lockdown to capture the immediate effect of lockdown, and 2 knots with 2 weeks apart afterwards to account for short-term and longer-term intervention effect. Our goal is to estimate the lockdown effects, the immediate effect, short-term and longer-term effects. US, which is 10 to 20 days behind Italy, in our paper we used 5 pieces, put 1 knot and the declaration of national emergency, and 3 weeks afterwards. And for our current forecast, we put additional knots to account for current intervention effects. So here are the results. For China, our model captures the peak date of daily new cases and the epidemic end date by only using 2 weeks data without any off-peak data. And for South Korea, next page. For South Korea, our model captures the general trend, except the tail area where some small outbreaks were observed.
5 minutes.
Okay, for Italy, we used training data up to April 29th, which was 7 weeks after lockdown. The trend till the early August still follows our predicted trend, although there are some small outbreaks recently. Also, we found that the rate of decrease after the peak is slower than rising. Next one. Compare the effective reproduction numbers RT. For China and South Korea, the RT reduces to below 1 in 2 weeks. In contrast, RT reduced to 1.02 in 42 days in Italy and remained at 1 for 3 weeks. Also, we found that the lockdown in Italy didn't significantly further reduce the rate of decrease. For US, RT reduced to 1.1 in 50 days and flat for 6 weeks. It never goes down below 1, and it increased again at the end of June. Next one. Here are the predictions for US. The left figure shows when we're using training data up to May 29th. If the trend keeps the trend at that time, then the epidemic will be end in early November with a total deaths 157,000, which was much lower than the current deaths. And from our model, the 95% confidence interval already observed an uptick by early June. And the right figure shows when we're using training data up to July 24th, when US was still at the second peak, and our model already predicted the decreasing trend in August. Next one. And here are some more current forecasts when we're using training data up to August 16th. To predict deaths, we jointly fit incidence cases and incidence deaths. If the RT keeps decreasing at the current rate, then the epidemic will be end in mid-December with a total deaths 214,000. However, if RT stops decreasing and remains constant at the current level, the epidemic will be end in next May. Next one. So in conclusion, in this work, we propose a simple model for predicting daily new cases, latent cases, RT, and comparison of mitigation strategies. Our method works well for short-term but not long-term with our assumptions. For model building, we may not need big data or any sophisticated predictive analytics. However, we do require reliable data sources, informative statistics, and scientific knowledge. And also, we see that simpler model and approach can be more useful and robust for population size. For limitations, our model didn't account for differences between countries. In our current work, we are considering modeling state-level data, evaluating the effect of public health interventions, for example, timing of imposing or lifting restrictions, mask wearing, and school reopening, and also account for covariates. Next. In the end, we also want to point out that how our statisticians can help during the pandemic. First, we can model disease transmission, study prognostic factors, design and analysis of treatment and vaccine trials. And the societal responses and behavioral changes are major tools for preventing another outbreak without a vaccine. So if we can have a good communication about risks with the public might be more willing to change their behaviors. For example, when we are talking about modality rate, we should consider high intensity and excess modality. Also, if we only report the no absolute risk to certain individuals, for example, younger adults, it does not convey their risks to vulnerable populations. Thank you for your attention. We are willing to take any questions.